Sir.
Thank you very much. Thank you very much for this kind introduction. And at the outset, I would like to thank Dr. Bansi Sabu and the entire team of Diabetes India for this invitation. Without wasting time, I think today I'm going to speak more about what are the new ways that we should treat patients with diabetes. All along, our journey has been that we've walked through, development of oral agents. And then, of course, we've seen a whole plethora of insulins that have come into the market. But something that some of the key areas that we have not really addressed, and that's the weight management, because that's something that is very key to our success with long term good control of diabetes. So the question was that what are the sort of gray areas where we are not looking at in our patients, which sort of preludes to any kind of failure of therapy. At some point of time, all our patients with diabetes will become insulin requiring diabetics. But the problem is how much of them adhere to insulin on a long term basis. And some of the reasons why people don't adhere to long term insulin therapy is because they have to inject multiple times in a day, or there is reduced flexibility in the current patterns of insulin deliveries, or the most important thing is the risk of hypoglycemia. One hypoglycemic attack sort of deters the patient from keeping good control, number one, and he starts doing defensive eating, which sort of causes a weight gain to happen. Now, along with this, obviously, you have to ask the patient to do a lot of lifestyle adjustments. And when the patient is on multiple injections, then he has to do a lot of changes in the timing of his meal, the composition of his meal, the portion size of his meals to ensure that there is not much of a glycemic variability and the risk of hypoglycemia that he may get. And obviously, with physical activity, you're trying to see that how best you can improve control, but by and large people are very sedentary today, and because people are sedentary, they with the insulin, which we know that can cause a weight gain to happen, so all this sort of with weight gain then causes a disturbance in the glycemic control. We have an excellent combination today which addresses the problem that we face today, not only with glycemic control but weight management. And if we can combine this together, then we are going to sort of probably solve a lot of these issues that I just talked about. We have a combination with GLP-1, that's lixisenatide, along with a basal insulin, that's glargine, and that's probably the way to go, where you're combining for the fasting, as Pratap just pointed out, fix the fasting, you can address glargine with that. And the post-meal glucose values, you can address it with the GLP-1 analog. But important is the fact that you get a lot of benefit in terms of weight management. So here's I'm going to present to you in the next couple of slides the data as to how this combination really helps our patients in terms of better control and weight management with the minimal risk of hypoglycemia. Now, we have all been talking about the octet which Dr. Ralph DeFranzo proposed, and we know these are the 8 pathways for development of diabetes. So if we have this combination which addresses most of these pathways, then it's going to be obviously very, very beneficial. So if you look at GLP-1 pathway that it addresses, so it increases the glucose-dependent insulin release, it reduces the glucose-dependent glucagon release, it improves satiety, and it reduces gastric emptying. Whereas the basal insulin decreases the hepatic glucose output and decreases the gluconeogenesis. It increases the glucose uptake in the muscles and reduces the lipolysis and free fatty acid generation. So obviously this marriage is very beneficial in the larger sense of the in terms of pathophysiological pathways to development of diabetes, and it's obviously the hypoglycemic curve that they are in. Now various societies have endorsed this. We've got the ADA, the ACE, ADA ESD guidelines, which have been developed on 2022, 2023, and 2025, which have propagated this concept of combining a GLP-1 analog with a basal insulin. And they have obviously shown that this combination is better than using maybe a basal plus or a basal bolus, or combining only a basal insulin with an oral agent alone. So what is the evidence of the combination? We've got number of studies which have been done by the innovator company. The solid study which combined Iglar Lixi versus IDEC ASP. So IDEC ASP is more like a premix. We talk about basal plus. So it kind of replicates the basal plus concept. Then we've got Lixalan O study which compared Iglar Lixi versus Iglar alone or lixisenatide alone. And then, of course, Iglar-Lixin type 2 diabetes suboptimally controlled on insulin. So we've got the Solumix study, which is Iglar-Lixi versus twice daily biasp, which is premixed insulin. And then Lixalan L study, which is Iglar-Lixi versus only basal, that's Iglar. And then Soliswitch study. So if you have somebody who's on a premixed insulin, then how do you shift this patient to Iglar-Lixi? So these are a couple of the studies, but for want of time, I'm not going to dwell on all these ones, but I'm just going to dwell on some of the important studies. One of them is, of course, the solid D style, which is a comparison of Iglar-Lixi versus IDAC ASP. So this was a study which is 24-week open label phase 3 study to compare the efficacy and safety of Iglar-Lixi with premixed insulin IDEC ASP. So IDEC ASP is Degludec with Aspart in Chinese adults with who are suboptimally controlled with type 2 diabetes on OADs. Now if you look at the trial population, then these were adults with more than or equal to 3 months on stable dose of metformin and or a second oral agent, which may be any of these which have been listed out there, having a BMI of less than 40, A1C between 7.5 to 11%, which if the patient's previously on SGLT2 inhibitors plus or minus metformin, or between 7 to 10 if they're previously on metformin and a non-SGLT2 agent. Now, after the initial screening and randomization, they were sort of in two groups, either Iglar-Lixi once daily or IDEC-ASP once daily. And the treatment duration was 24 weeks followed by a follow-up period. The endpoint was basically a non-inferiority study in the A1C from baseline to 24 weeks. So if you look at the results, you can clearly see that there was a better reduction in the A1C value against Iglar. So that if you see here, there's almost a sort of odds ratio reduction of 1.88, the patients who are on IDEC ASP versus patients, on Iglar-Lixi versus IDEC ASP. So clearly it shows that when you use this combination, you get a better A1C reduction. Now, when you look at the design for non-inferiority, you have a p-value that is significant. When you look at for the superiority, then you don't have a p-value that is significant. So obviously this has worked out very well in terms of, but the benefit other than A1C reduction was in terms of other confounding sort of endpoints that we were looking at. So if you look at weight, you find that there is a weight loss that happened with this combination versus weight gain that happened with IDEC ASP. And if you look at three endpoints, that's HbA1c of less than 7% at week 24, HbA1c less than 7% without body weight gain at week 24. And then if you look at HbA1c less than 7% with no body weight gain or minimal or no hypoglycemia during treatment, you find the combination of Iglar-Lixi was far superior as compared to IDEC ASP. Again, if you look at the CGM graphs, you find that there is very minimal glycemic variability that you tend to get, and the overall insulin dose requirement was much lower with the combination of Iglar-Lixi as compared to IDEC ASP. What about hypoglycemia? Because that's always been a concern for us, and you can see clearly with all levels of hypoglycemia, any hypoglycemia or nocturnal hypoglycemia, the rates of hypoglycemia were lower with patients who are on Iglar-Lixi as compared to IDEC ASP. So if I have to summarize this trial, then there was a non-inferiority and statistical superiority in the A1C reduction with the combination of Iglar-Lixi, superior body weight benefit, more patients achieved composite endpoints, low risk of hypoglycemic events, and there was no unexpected safety findings. So Agarwal should be considered as a valuable option for advancing therapy in patients with type 2 diabetes suboptimally controlled on oral agents. The second study is, of course, the Agarwal in type 2 patients who are suboptimally controlled on insulin. And this was a solely mixed trial where they compared Agarwal against a bias 30, which is a premixed insulin. And there was another study, the solely switch study, that how do you switch to Agarwal when the patient is on premixed insulin. So here's a trial design. This was a multicentric, open label, randomized 26-week phase 3B study to compare the efficacy and safety of Agarwal versus bias 30 in adults with type 2 diabetes for advancing from basal insulin with oral agents. Here you've got type 2 diabetes who have been more than or equal to 1 year, age group of more than or equal to 18 years. Patients have been on basal insulin with oral agents for more than or equal to 3 months, and A1C is between 7.5 to 10%, BMI between 20 to 40, and basal insulin dose at screening was between 20 to 50 units. They were randomized to two groups. One was Agarwal once daily, and the other one is, of course, on the premixed bias 30. And they were followed up for 3 days, and the entire duration of the drug treatment was 26 weeks. There was almost about 182 population from India which was included into the study. So what do the results show you? There was a superior A1C reduction with the Agarwal combination, and there was a non-inferiority which was achieved with this combination. Even the superiority was achieved as against the premixed insulin, and this was the p-values were significant. Not only that, if you look at the body weight reduction, you find that with the combination of Agarwal there was 0.7 kilograms of weight loss against a 1.2 kilogram weight gain that happened with the premixed insulin. If you look at the endpoints, the three important endpoints, that was A1C of less than 7%, A1C less than 7% without weight gain, and A1C of less than 7% without weight gain and hypoglycemia. Clearly, you can see the secondary endpoints. The combination of Agarwal scored over the premixed insulin bias 30. And if you look at the total dose of insulin that was given to an individual patient, it was much lower in the combination of Agarwal as against the premixed insulin. If you look at the incidence of hypoglycemias, which is something that we are all concerned about, all levels of hypoglycemia, any hypoglycemia and nocturnal hypoglycemia were much lower with the combination of Agarwal, which gives you a sense of confidence to use the drug. Because one of the main reasons for intensification and fast titration of an insulin is we are always concerned that will this patient tend to develop nocturnal hypoglycemia or daytime hypoglycemias. And if you have a confidence in a particular combination which sort of reduces the risk of nocturnal hypoglycemia, then you're able to titrate these patients much better to get them to goals. In terms of if I have to summarize this trial, then Agarwal versus bias, then better glycemic control with weight benefit, there's less hypoglycemia, fewer daily injections, and similar proportions of serious adverse events in both the treatment groups. So Agarwal was efficacious, simpler, and well-tolerated alternative to premixed bias 30 in uncontrolled type 2 diabetes. What about the solely switch study, which we talked about? And this is perhaps going to be the last study that I'm going to discuss to you about. This is again an adult, this was a 24-week single-arm phase 4 study to assess the efficacy and safety of switching premixed insulin to Agarwal in patients with type 2 diabetes. The trial population has been outlined over here, but there was initially a twice weekly titration that was done with this combination. And then after week 12, there was a once weekly titration. The total duration of the drug treatment was 24 weeks, and there was a follow-up period. The primary endpoint was, of course, change in the A1C from baseline to 24 weeks. And clearly, you can see here the switch that was outlined. So you can see the dose equivalents that were used from premixed to Agarwal when you look at dose to dose when you're switching over. What was the difference in the A1Cs? You can see here from the baseline to week 24, there was almost about 1.2% reduction in the A1C values when you use the combination of Agarwal. If you look at all the secondary endpoints, participants switched to Iglar elixir with adequate glycemic control. Again, A1C less than 7%, A1C 7% without relevant hypoglycemia, and then last one is of course without relevant hypoglycemia and weight gain. You find that in all these endpoints, Iglar elixir is scored over. And the amount of insulin dose reduction did not very significantly change, but it definitely did not go up when you use the combination. If you look at the change in fasting plasma glucose, you find that there is a great change. You get almost about 45 milligram percent change. Change in post-meal glucose values, again, there was a benefit with the combination. And change in body weight, again, there was a reduction in the body weight that was achieved with this combination. How do you sort of, I'm going to sum up by saying that how do you really use this combination? That's the most important part of it. So you have the ratio of 2 units to 1 microgram of glargine with lixisenatide. And in a single pen, there are 300 units of insulin glargine and 150 microgram of lixisenatide and 10 dose steps to 40 dose steps. So you've got all these combinations. So the way to titrate is you do it as per the glargine number of units and not against the lixisenatide. So you can rotate, you start with 10 units and then you can up titrate the glargine dose and you'll get an equivalent amount of lixisenatide. So it's very simple to titrate. And if you have a glucose value between 100 to 140, you go up by 2 units. If it's between 80 to 100, you do no change. If it's less than 80, you come down by 2 units. It should be given usually subcutaneous once a day within 1 hour prior to a meal. It is preferable that the prandial injection is performed the same meal every day. And in case you miss a dose, then it should be given within the hour prior to the next meal. In special populations that we are concerned about, in the elderly population, very safe because that's something we are very, very concerned in terms of treatment. Renal impaired, again, you find that these can be clearly given. Only thing it is not recommended for patients who got a GFR of less than 30. Hepatic impairment, you can use it very clearly. No dose adjustments are required in these patients. Pregnancy, of course, is a red flag. You don't use it in pregnant population. So in summary, you find that this combination achieves many goals. One is, of course, the compliance because it is once a day. The weight benefits that you get out of it. The lower rates of hypoglycemia, which is a concern when you're intensifying therapies. Improved GI tolerability versus monocomponents. More people achieving glycemic goals by addressing multiple pathophysiological pathways. And you're getting both fasting, post-meal controls, and there is an effective A1C reduction. The SOLID trial indicates that Iglar elixir is a simple, well-tolerated treatment with better glycemic control, body weight benefit, and lower hypoglycemia event rates compared to iodic asp. The SOLIMIX trial indicates that the Iglar elixir is efficacious, simpler, well-tolerated alternative to premix bias 30 that provides better glycemic control with weight benefit and less hypoglycemia. So it's once a day, 1 injection, 1 hour prior to meal. So remember the figure 1. Thank you very much for your patient listening.